Good afternoon, everyone. This is Patty Cassena from Mountain Pacific Quality Health, and we're here today to talk about using narrative medicine for care team resilience and patient engagement. So thanks everyone for joining us. Next slide, please, Mary Jane. This presentation is being brought to you by the Regional Chronic Disease Collaborative, and the partners include the Departments of Health from Montana, Wyoming, Alaska, Hawaii, the primary cares from Montana and Alaska, and also the American Heart Association. Next slide. So a few housekeeping items. On purpose, we created this as a Zoom meeting and not a webinar because we're encouraging participation from all of you. So your mics are all open. So if you're not speaking, please mute them to try to eliminate background noise. And this is all about sharing. So be prepared to share. We're not here to really speak at you. We want you to join in on the conversation, and feel free to come off mute when you want to talk, or even if you're bold and brave and you took a shower today, go ahead and put on your video. That'd be fine too. We'd like to see you. And if you don't have audio or you'd rather not, go ahead and chat your questions, put them in chat, and we'll be monitoring those questions and bringing them up to the speaker. Next slide. So just a couple of ground rules. We're all going through a lot of things, and these are just good ground rules to remember that assume positive intent. We're all here to try to add value and help each other out, and try to be present and be prepared to share. This is all about sharing what you need, what you know, what your questions are. Try to respect each other's time and minimize distraction. And then the big one is everyone teaches, everyone learns. No one here is really the expert, but we really learn from each other. Next slide. So it is my privilege to present today's, to introduce today's presenter. It's Mary Jane Nealon from the Montana Primary Care Association, and she is going to lead us through this really valuable topic. So go ahead, Mary Jane.
Thank you, Patty, and good afternoon to everyone. Just briefly, I have no conflicts to disclose, and there's no copyright infringement intended on any of the photos and any of the slides. They've all been available for public use, but we'll say that one time. And just a disclaimer, because we mentioned resiliency, this is a historic time we are living through, we hope, but we are still living in it. And for many people, but especially those in healthcare and those on the front lines, this has been a really challenging time. So in this presentation, resiliency is meant to offer a tool for patient engagement that we hope might help people re-engage in the clinical relationship with joy and new hope. It's not a therapeutic training, and it's not meant to take the place of any mental health support that may be available to you. And just in terms of resiliency, and I won't read this quote, but it's from the US Department of Health and Human Services, SAMHSA. The idea that many of us have a resilience for brief intermittent trauma. What I don't think we know is what is going to happen to so many of us and people in healthcare, because this thing is so extended and so without end. So my interest in this topic was actually before it was a specialty that had schooling and everything associated with it. I was interested in stories between patients and caregivers. I've always worked as a writer and as a nurse. I have my master's in fine arts and my RN. And in the late 80s, early 90s, I was involved in a storytelling practice for people with AIDS, where when they were facing their mortality, we would sit and tell them their story back. Like we would gather information and then say, and then remember you were in that play on Broadway. And it was a way to kind of help people prepare for death. I've also taught writing workshops to cancer survivors, immigrants through the library system in New York, and prisoners on Rikers Island. And I worked as a nurse in a homeless shelter for a long time, and I had playwrights come in and we did drama workshops. And then finally, I presented a journal keeping tool that was used for self-awareness for people with cancer at the National Institutes of Health. So I am a passionate believer of language and care. So the objectives for today are fairly straightforward. Just number one, I think we need to take some time to acknowledge what we've been living through and consider its impact on patient engagement. To introduce the concept of narrative medicine and why I think anyway, this is the ideal time to consider using it. And then three, just very briefly to mention next steps if you want to become more competent in narrative medicine. As Patty said, please feel free to unmute, shout out, do anything, put a question in a chat if you want to stop me while we go, okay? So for part one, I think it's worth taking some time to just reflect on where we are. And to do that, I started asking myself, how have we changed since early 2020? Well, the truth is almost everybody looking at those logos in this regional partnership, everyone was doing good work, and that good work was interrupted. Our sense of safety was disrupted. And while we might have confronted losing a sense of safety at work, many of us had a sense of safety at home, and that was also disrupted. And then the line between work and home exploded, and it felt like everything got harder. The kinds of things you would do to recharge were also threatened. And then ultimately we lost time, and I still don't think we know how much time we've lost, but the time we mainly lost was time with others, especially if it was people who were more vulnerable, older, very young. And we lost the ability to have our rituals, weddings, graduations, celebrating new babies, funerals. So I was thinking, we won't have a lot of time. This is not a story writing process, but what makes a very short story? A very short story is a headline. So the headlines from the first week in January 2020, when none of us knew this was on the horizon, we were hopefully, most people on New Year's have a sense of hope. 1 week earlier, the New York Times international front page, French chef loses battle over a lost Michelin star. Merkel's New Year's speech calls for action on climate and tolerance. Japan loves robots, but getting them to do human work isn't easy. And my favorite, a couple unwittingly threw away $20,000. The dump gave it back. So then on January 8th, New York Times, so a week later, China identifies new virus causing pneumonia-like illness. One disclaimer, I avoided political headlines. Then 2 weeks after that, first patient with Wuhan coronavirus is identified in the US. January 30th, 2020, World Health Organization declares global emergency. February 8th, first American dies of coronavirus. And then I actually remember reading this headline on February 26th, admit it, you don't know what will happen next. And then March 16th, to battle virus, 7 California counties order everyone to stay home. And I think everyone probably remembers, whether you do Facebook, Instagram, TikTok, there were a series of healthcare providers, firefighters, saying, we stay here for you, please stay home for us. And then on March 26th of 2020, so now we're not even 3 months into the year, God doesn't want us to sacrifice the old. And then skip ahead, well, we're in December today, but October 2nd of 2021, global COVID-19 deaths hit 5 million as Delta variant sweeps the world. It is hard to look at those headlines because that wasn't one short story. That took us, what, a minute and a half maybe to read it. That is a big story. It's a big novel, and it's impacted all of us, no matter what our roles are. So I want us to take 1 minute, write your headline, and it can be anything. It can be a headline for your community, for your family, something that happened to you, something that you want to happen, just one headline. You don't have to share it. If you feel like typing it in the chat, we'd love if we have some in the chat, we'll just read them out loud. We don't have to say who they're from, but just to get a sense of where everybody is out there, okay? So just take that minute.
Mary Jane, are you able to see the chat or do you want me to read?
Oh, I can, whatever,
Okay.
yeah.
All right.
I'll just give people a little bit more time, maybe.
What would you?
And I just like to acknowledge that, you know, I'm a poet, so sometimes my voice cracks with emotion because I've spent my whole life trying to nurture it and not turn it off. So I'll read you the handful that we have, and if more come in, I'll continue to do that for a minute. Family matters more than ever. Why are we so fearful? Help me, help you. Will the new normal ever end? Long impacts to kids from lost time. Life resigned, reprioritizing life after health, life redesigned, reprioritizing life after health crisis. Thank you for everyone who did that. So I'd love to, I have like a very sensitive touchpad. I'd love us to just talk for a minute. Anybody who wants to unmute or say something in the chat about what it felt like to go through those headlines, or did any one headline more than another kind of touch where you are now?
Hi, this is Emily Burton from Mountain Pacific, and I recently joined in March, coming from a hospital system. So I saw most of the pandemic in a hospital setting, and my husband has worked in a COVID unit and still does. And it's just, I'm tearful as well. It's devastating. And I think we've been through, as a family, we've been through all of those emotions of fear and reprioritizing, redesigning, as I mistyped and hopefully made everybody giggle a little in the chat. And then really looking at our priorities and hope and making the most of every day. Looking at how we're spending our time together and the work that we choose to do. So we've chose to really look at the positives and the lessons that we've learned, but it's taken us, I mean, we're almost a full 2 years from the time my husband took care of his first COVID patient. So it's been a long journey, and you know, we're one tiny story of millions and millions of healthcare providers that have been through this, and families and everybody that's been touched by this. So very moving presentation so far. Thank you so much for being here.
Thank you, Emily. Anyone else?
Mary Jane, this is Patty. I'll just say, I think the headline that grabbed me the most was the 5 million. Just such a number, you know, I don't know that I heard that, and that's shocking to me.
Mm-hmm.
This is Mackenzie. I took a little bit more time to write my headline, but be kind, patient, and empathetic. I felt the headline that when you put up about the doctors saying like we stay here for you, stay home for us, that gave me chills. I think we all remember that, but it feels so distant at this moment. But to be reminded that that was a time when it was devastating, but we were still there for each other. We were trying to be there for each other in whatever way possible.
Yeah, thank you. I'm sorry, I didn't see that. There were a couple more in the chat. So surreal, where has hope gone? And be kind, patient, and empathetic, a way to move forward. So thank you, Mackenzie. I worked in the AIDS epidemic in New York City early and for a long time. And I didn't know at the time that I was living through a historic moment. And so it really struck me now when I wasn't on the front line and I knew people were, to say, I hope that they understand they're gonna pay a price for this. And there are ways we can try to kind of support one another to go through, like Mackenzie, what you mentioned about like being there for one another, or Emily, how you're supporting your husband. This is, it reminds me of everyone going to wakes together in the AIDS epidemic, and physicians went to funerals, and all those boundary lines kind of broke because it was the only way to get through. So if anybody else has other thoughts as we go, please jump in, but I'll move forward. So part of our grief is that it's really uncertain. The time, we know we're living through a historic time, but we don't actually know when it's going to end. And Ellen Bryant Voigt, I don't know how many people know poetry, but Ellen Bryant Voigt is a really important voice in poetry. And she has an entire book about the 1918 flu pandemic, 1718, called Kiri. And this is one very small excerpt from her long poem. Who said the worst was past? Who knew such a thing? Someone writing history, someone looking down on us from the clouds. Down here, snow and wind, cold blew through the clapboards. Our spring was frozen in the frozen ground. Like the beasts in their holes, no one stirred, if not sick, exhausted, or afraid. In the village, the doctor's own wife died in the night of the 19th, 1919. But it was true. At the window, every afternoon toward the horizon, a little more light before the darkness fell. And this really struck me, especially those first couple lines. Who said the worst was past? Who knew such a thing? Someone writing history. And then you see that the night she talks about the doctor's wife dying is 1919. So they were coming out of it, but were not aware. So that's an incredible poetry book. I encourage people to think about poetry as a place to hide during these times, because it doesn't take that long to read a poem or to share a poem, and it can be a touchstone of sorts. So now I just want to do a brief introduction to narrative medicine. And I kind of wish I had done a poll. Now it's too late, but wondering how many people have practiced narrative medicine or heard of narrative medicine. So if you have a story to tell about that, please feel free to unmute, or even just put in the chat, like, I can tell a story at a break, or whatever you're comfortable with. So there was an article, well, I'll just flip to this next slide. So what is narrative? So narrative is a story that can be analyzed for meaning, not necessarily medical narrative, but any story. And stories are foundational to our lives. So a number of years ago, I forget the author's name, but I think it was Michael Pollard, wrote an article about the cooking shows and how everybody was starting to obsess watching cooking shows, watching the Food Channel. And he likened it to the fact that as a culture, we were really longing for the community we used to have around the table. And the upshot was, as people started watching these shows more, they actually started cooking more. And so he felt there was this real pull back to, when we were more tribal around a campfire and how we kept community together. To me, story goes along with that cooking metaphor, because when people sat around a campfire together or around a dinner table together, that was often a time of storytelling. So narrative medicine just builds on that, and it says, this is a story that can be used to help answer clinical questions we have. It can help us best know how to engage with patients and take care of one another. Hippocrates said over 2,400 years ago, it is more important to know what sort of person has a disease than to know what sort of a disease a person has. But many of you, I worked a long time, I'm semi-retired, but Courtney is the person who got me to stop saying diabetics and to say a person with diabetes or a person living with diabetes. And for those of us in healthcare, I'm sure you can remember times when we were like, no, go see the asthmatic in room 9. Don't go see the chest pain. It's very easy to kind of categorize when you're in a hurry and you're under a lot of stress. And in doing that, you lose the bit of the person that is unique. So some of the things with kind of traditional stories, right, is that we're used to them being very linear, although certainly in the culture, the things we read now are often surprising in terms of structure. But for a patient, if you're listening to their story, you have to kind of assume that the story is not going to be right in front of you, that it's going to take a little bit more work. Because if people get anxious, they can, lose the plot. And they might use a metaphor, even unintentionally. They might be really dramatic. I think most of us in healthcare know that person that comes in and is kind of like falling apart, and it takes you a while to figure out what it is that they're going through. And often we want to get to the facts, like, but did you get the lab work? Can we see that lab report? Did you go get that x-ray? But the truth is, we know now it's also scientific to listen to story. So question for discussion, just thoughts. There's actually no right or wrong answer. I'm kind of giving it away, but the doctor and a patient are in the room. Who do you think is the narrator? Anybody?
I would say patient.
Okay.
I would say patient too. I would say patient too, but in reality, it doesn't happen that way.
Can you say a little more about that, Agnes?
Well, because in our training, we're very didactic. We're told to tell the patients what's going on and what to do and not to listen. I work for Mountain Pacific, and I'm a diabetes educator. And I've learned in the decades of doing diabetes education, and of course my technique has changed and has morphed because it's not what we tell them. I switch everything now. I say I can talk you blue in the face about diabetes and how to control it, but tell me, what do you want from me? And that's how I frame everything now. What is your goal, and what do you want from me, and how can we get to that one goal? One guy just said, I want to eat this much salt, and he just showed me his pinky finger. And I said, hallelujah, amen. That's the easiest thing to do. Okay, we'll go. It's just, so things have changed. And I had a boss in a home care job. She said, I want you to take, some of these new nurses out and show them what you do. I said, they will think, Ruth, they will think I'm just shooting the breeze with these patients, because that's what it sounds like.
Yeah.
Well,
Yeah.
I've changed my technique.
Thank you. Well, it was a perfect lead up to my next slide, Agnes, so thank you, which is that sometimes there is a story that we have to tell as nurses or providers or educators when we are giving instructions. And we might say, this is what I think is wrong. This is what I think you should do. Maybe the story or instructions or visit summary are even written down. Maybe the patient actually came for this narrative. And it works some of the time. So therefore it becomes a habit or a process that we're really comfortable with. One of the most interesting studies I read recently said that 68% of the people who are given their visit summaries take them home and read them. 30-something% share them with other people and then actually change something about their behavior or their care. So they've kind of been given a written summary that they get to take with them. And that is a kind of story. The problem is it doesn't always work. And if it doesn't work, like what happens next, right? So there's a lot of reasons it might not work. Patients might not understand what is being said. They might not want to engage in a narrative where they have to quit smoking or walk more or take medicine. So they never get better. They never do what they're quote unquote supposed to do. We feel bad or we blame them or we're frustrated. And even though both the provider and the patient, the nurse and the patient, everybody wants a good outcome, but something is missing. And I see there's something in the chat. I don't know if Patty, if you could look at that and just let me know if I should stop. So when the patient is the narrator, it also might not work because they may not give the appropriate clues to the provider. They might be unable or unwilling. Sometimes people have a lot of shame. They fear being judged. Those things can keep you from telling the truth. And then everybody knows external pressures such as time might limit the provider's ability to listen. So I didn't directly work with this patient, but we had a patient advisory council, and we had a patient with diabetes on the advisory council. And he told us this story in one of our meetings, which was that he was a single father of a teenager, and he didn't know he had diabetes, and he became critically ill and was in the intensive care unit. And one of the providers in the intensive care unit told him, you need to figure out what to do for your son because you could die from this. And they weren't sure he was going to make it through the ICU, which of course just sent him into a tailspin. And he met with social workers and tried to contact family. And then he wound up getting better and got moved to a floor and then got transferred to our outpatient clinic. And at some point, people started having him meet with our diabetes educator and gave him prescriptions. But nobody ever said to him, oh, you're not going to die. You don't have to die from this now. This is like in your control. And so he was never able to absorb any of the education he was given because nobody had ever stopped him on that path of thinking, how do I prepare my son for me to die? So at that point, he obviously was not going to engage in the way that you might anticipate he would in a visit. So relationships are built over time, right? I mean, patient engagement is about connectedness. And I wanted to just tell you one other little story. So I used to work in a homeless shelter for men with AIDS in New York City. And this fairly new discharge from Rikers Island. So this guy had been in prison for, I don't know, 15 or 20 years, a long time. He had AIDS, and he went to his first visit with his new HIV doctor. And he comes back to the shelter and he's enraged. And so I pull him into my cubicle and I'm like, I don't know what happened, but don't get kicked out. Like, just calm down. And he's like, oh, he judged me because of the way my teeth looked. And I just felt like he was really treating me like, and he just went through this whole thing of how it felt. And so I just said to him, who are the two closest people in your life? And he said his sister and someone else. And I said, and have you been that close to them since day one? And he was like, well, no. I mean, I grew up with my sister and it's like, exactly. So when you go back next week, because he had gotten blood work and was returning, I want you to practice telling the doctor how you feel. See if you can and we role played. And he finally got to where he could calmly say, I felt really disrespected. I felt like you didn't care about me. And the following week, he comes into the shelter and he was so happy. The provider was floored and felt terrible. Of course, the provider was just really busy and was like, I don't have this guy's records from prison. Has he not had dental care the whole 20 years? Like the provider's anxiety was high. They wound up having a really great therapeutic relationship. A part of it was helping to guide the patient into what to say to reflect his truth, right? So some of the environment is, and I think we've gotten much better at this, is recognizing the power structure that exists and acknowledging time limitations up front. I often say to my doctor, because I go to the health center I used to work at, like, don't you need to go? Like, I'm okay. Like, don't you have another patient waiting for you? But many people don't know that the pressure that our providers are under. So for a provider, you can even say, I really want to ask you more about your family. Can we make a note that we're going to do that the next time I see you? Or I love the idea of inviting people to use the portal between visits. So to say, that would be important to me to know more about that, or about what happens when you see the dermatologist. So they'll send me a note, but feel free to let me know how it went for you in between visits. It's, every single patient in our patient family council at my old health center mentioned that they feel eye contact is a thing of the past, whether they're checking in at reception, getting lab work, meeting with the nurse, and often answering extremely personal questions about their health. They say they feel like the people are just looking at the computer screen. And so I know that there's a lot of discussion in a lot of settings about how to manage that, but it's a true experience for our patients. And then I think we have gotten really good about like the exam table, and then inviting people down from the exam table to sit in a chair and to sit alongside for instructions. But it's good to always think that that's part of the environment we have to set if we want to hear a story. So I don't know how many people have heard of Rita Sharon. In one of the final slides, there's a reference list, and I put in a link to a YouTube. It's 18 minutes, a TEDx talk she does in Atlanta, where she really does a beautiful job of explaining narrative medicine. And one of the things she talks about is a patient she had with cancer who had a lumpectomy, had a very good prognosis, was expected to be cancer-free, and then 5 years later has a recurrence, and then starts to have, and seems to handle the recurrence very well, and has a mastectomy. But then starts to have, pain and worry of infection, and I forget exactly how she describes it, but I think we all know that. Like, we know those patients when we see them, when they're like calling with a lot of vague things and you can't quite pin down a problem. And so what she realizes is that the story this woman is saying is, I thought I was cured of cancer. The cancer came back. I have looked death in the eye and I'm terrified. This was a life-altering experience. And now I don't trust you know, my body. I don't trust that pains are not serious things. But the patient was never able to articulate the story, but the physician over time in this relationship was like, I'm going to tell you this is what I think is happening, and I'm just going to promise you that I will stand alongside you. And then she describes kind of the positive stuff that comes out of that. So it's a really valuable 18 minutes if you can listen to it. And so she says narrative medicine is a commitment to understanding patients' lives, caring for the caregivers, and giving voice to the suffering. So this is just, in your arsenal of many tools, one more tool, right? If you listen for stories, sometimes they're buried. Why are they telling me this now? Why am I getting an emotional reaction? Why am I angry or sad as they tell me this thing? Why does she keep bringing up her sister's accident in the story of her bellyache? At the clinic I worked at in Missoula, there was one of our doctors there is so extraordinary, and he's been a backbone provider there for almost 10 years. Yeah, at some point he had like 2,100 people on his panel, you know, and didn't want to close to new patients, and just extraordinary. And I was doing a study, and I went up to him and I said, hey, could I approach this person of yours for the study? And I started to like remind him who she was. And he said, oh no, I don't want her to do that. I know this sounds crazy, but both her parents died in a plane crash when she was 5. And this kind of thing will really unnerve her. And it was extraordinary to me that, like, in this chart that went on for years, it was filled with medication, diagnosis, treatment. He remembered that core piece of her life that he knew meant she would not be a good fit for my study. And so it just moved me a lot to know that he had made that link. So if we kind of, and please, if there's any questions, I'm gonna look in the chat because I see the number 2 and I just wanna make sure I'm not missing anything.
You're doing good, Mary Jane.
Okay.
I'm keeping an eye on it.
Okay.
I have a quick question, Mary Jane.
Yes.
This is Agnes White.
Yes.
I have in this day and age and in our work, we have to show data and prove our interventions are effective and are working based on our data. Now with narrative medicine, how do you concretize, or how do you, measure how well this is, if you're going to do a 6-month study, 1-year study, because, grants only have so much of a time, and it takes time to establish relationships with individuals, and it may take years and you may not see results. So how do you report, how do you do your reporting, so to speak, so that you can show facts that say this is very important and this has to be funded? So I guess that's
right.
The bottom line.
Well, I love that. I love that question, because I don't think it's anything that has to be funded in itself. I don't think it needs to generate data. I think we're still looking at the same data endpoints. We still want people with diabetes to have an A1C that's the best goal for them. We still want people with high blood pressure or hypertension to have a managed blood pressure. What I think narrative medicine does, because we already know, right, Agnes, that you can work with somebody for 4 years and not get a positive outcome. And they're still reflected as a gap in care in your data. So it's more that this is another tool to really help you engage them so that they do those more traditional things. Here's a really simple example. Is I had staff, we actually worked with Mountain Pacific Quality Health on the motivational interviewing part of this project, but we had a 2-year funded project for high utilizers of emergency and hospital services. And my team consisted of 2 men, a nurse, and a behavioral health care manager that went to people's homes. And one of the things they did, despite all the great ideas we had from everyone, is they only asked one question on their first home visit. What top 3 things are you most worried about now, whether or not it's related to your health? And I can tell you almost 90% of the time, it was nothing to do with their health. They had a dog that they loved. They couldn't afford to pay for the license fee. They'd been contacted by animal control. They were afraid they were going to lose their dog. It was all they could think about. So various things like that. And when that team would say, we are going to find a way to get that $37 for you to license your dog, they'd go to some local charity. Or one time they called me and said, this person had a shower delivered, but they won't bring it in the trailer. Can we bring it in the trailer? I was like, absolutely. Just don't write it in the note, get the shower in the trailer. And we estimated after the first year that for just 18 patients, we had saved Medicaid $560,000. They looked at real data and came back to us and said it was actually over $1 million, because prior to the intervention, their hospitalizations were kind of unfocused, lasted about 10 days. And after the intervention, even if they were hospitalized, it was for much shorter stays, like 3-day focused hospitalization. Prior to going in the program, if they had gone to the emergency department, they almost were never hospitalized. After the intervention, I forget the percentage, but it was high, of people who went to the ED actually got hospitalized, which meant it was appropriate use of the emergency department. So, that was data, but it wasn't data we were going for with that one question. We were going for trust, for the ability, for building the relationship, so someone would know how committed we were to them. And so that is kind of, for patient engagement, number 1, relationships develop over time. If you address the most critical needs someone has, even if it's not related to their health issue, they are going to work with you on those health issues eventually. And then invite tools such as notes that people write or recordings. In my journal keeping thing, my chemotherapy patients kept a journal. Sometimes all they did was write the date and the weather down. And then at the end of 6 months, they still felt they had lived through a lot. But that practice meant that on one particular day, if they were like, my mouth sores have never been like this, or something different, they could write that sentence down and bring it to their visit. I know everybody loves everything to be electronic, but I love an old paper chart with pictures. And when I worked with people with AIDS, I had one that had like walking, a pill box, a cigarette with an arrow through it, and I would say, here's 5 goals, just pick one. And why don't you pick one you're pretty close to achieving? And lots of times people would pick medication adherence because they were trying really hard. And then when they met that goal, we'd say, okay, now let's pick a harder one, and they had that piece of paper they carried with them. And then the most important tool, obviously, is learning to listen to one another. So I want to be conscious of time. So going forward, it sounds kind of crazy, but the main way to develop narrative competence, short of taking a class with Dr. Sharon, or, there are a lot of health programs now that actually employ writers to work with their staff. But one way is to just read stories. It keeps you open when the instinct might be to close off. We're all very conscious of healthy boundaries with patients, but you have to get pretty close to have this work. Virginia Woolf says, open your mind as widely as possible. Then signs and hints of almost imperceptible fineness will bring you into the presence of a human being unlike any other. And this quote just killed me because it made me so happy that law schools are starting to use storytelling to train their folks. And this quote, these stories full of complexity, contradiction, and looping back parallel the often complicated and multi-layered, multi-directional experiences of clients who come to the clinic. But it's a legal clinic. And it's exactly what it's like sometimes to get to a patient's truth with them. So one of the main things we have to do when we meet a patient, I believe, is accept the anti-narrative, anti from the Latin meaning before. Everybody comes to us with a very complicated story that cannot be shared in one visit or 10 visits. These relationships take a long time, and trust is the number one thing people are going to want from us before they're going to work on their goals. So that is all I have. And I know Patricia has some things, but are there any questions? Or I know it's a little disruptive to stop screen sharing, isn't it, Patty? I'm wondering if we should do your slides and then we could stop screen share in case people.
Well, either way, if you want to come up and then share them, I think if you want to open it up for questions or comments or feedback from anyone on the presentation, now would be the time for that for sure. And then we really just have some resources and polling to share with you. So if you want to go off, if it's easier for you,
Okay.
Mary Jane, that's fine.
Okay, and I'll just say my contact info, if anybody has thoughts after, is at the end, and then I have a couple resources for people. So I'm going to stop sharing just in case there are faces to see or thoughts.
I do have a question. Sorry, I just have a lot of questions because I find this very interesting. You know, literacy is a really important thing here. I'm on Guam, and the literacy levels are very, very low. We have many immigrants from the different islands around Guam. We have so many, people from Asia here. And so language and actually using language, how do you do that if English is not their first language? And how do you have them express themselves if you don't even understand their language or what they have written down? So how do you address that?
So it's interesting. I mean, of course, health centers, I mean, we have to provide opportunities for interpreting, but you also can't necessarily understand someone's story if the culture is very far. But I will tell you, I worked with immigrants in New York City who were learning English and learning to write in storytelling at the same time at the library. And some of the most phenomenal stories that people wrote, they could barely even read them. Like they were practicing learning to write English, but they were not really fluent. And those stories were so powerful, just because it was also a glimpse into everything they were dealing with in the culture. I think that's the other reason I love pictures for goal setting too, as like an additional tool. But yeah, it is a barrier. And I don't know if anybody else has a better answer to that. I welcome it.
Thank you.
Thank you, Agnes. Any other thoughts or questions?
Hi, Mary Jane. My question is, this is Courtney. I don't know if you see my box.
Yes, I
up.
can see.
My question is, so folks have watched this presentation and they're super excited. What would be the next step as they think about how they could integrate narrative medicine into their lives or their practice?
So I think, that 18-minute YouTube of Dr. Rita Sharon, she has a book, but that 18-minute YouTube is really powerful because she talks about how as practitioners, we're used to analyzing systems from the head down. I mean, we've all filled out those forms, and she starts out differently and says, something like, what do you want me to know about you? What do you think I need to know about you? And, there's been other articles separate from narrative medicine where it says, if you ask somebody, if somebody has abdominal pain and you ask them, what has your week been like? Or what is your life like today? They're going to tell you about their abdominal pain. They're just more likely to tell it in a way that really helps them explain where they are. And then there are writing groups for healthcare professionals, which is another way, to just learn about story. I still participate in poetry writing workshops, in nonfiction workshops. Even though I've been published and I've taught those classes, I still take them because we can still learn better, like what should we pay attention to the most in a story. So I don't know if that's helpful at all.
Yes, thank you.
Okay, is there anything else, Patty? Maybe should I put your stuff up, and if people think of a question, you can put it in the chat?
I sure will. And Mary Jane, I just wanted to share with you that my mother, who's turning 87 this week, is in the room sitting with me and listened to you. And she worked during the AIDS epidemic as a nurse as well, and loves writing. So she wants to be your friend.
Oh, I definitely am always open to a friend. Yes, that would be wonderful. Okay.
Yeah. So if you want to put
Great.
the slides up, I think all it is, and Mary Argonis, if you want to, let me just wait. Sorry to yell at my dog. Can you go to the next slide, Mary Jane?
Oh, is it on my dog? Okay.
No, my dog was making
Oh.
noise, so I had to yell.
Oh, okay.
So yeah, so the next thing that we want to do, so the Regional Chronic Disease Collaborative works together across our region to bring you education. And we'd really like to hear from you what other or your next education interests would be, so that we want to continue to bring valuable resources to you and speakers like we did today with Mary Jane, who did an amazing job. So if you would take a minute and poll, I think it's a multiple choice question, what you might be interested in. You might have to expand the window to get the full question. It looks like, yeah, the question, you might have to open the window a little bit on the pop-up box. But if you would do that, that would be great.
Are you talking to me, Patty?
No, everyone
Oh.
who is on,
Okay.
a poll should have popped up.
Yeah,
So
I can see it. I can
Yep.
see the poll.
Yeah, and it doesn't wrap the questions. You might have to expand the box is all I'm saying to read the full thing. And we will be presenting quarterly over the next year. And anytime you have a good idea for a topic, we're very interested in trying to present things that are relevant and helpful to the healthcare community. So we'll just give that another minute or 10 seconds, really. Okay, Mary Argonis, I think that's good. Oh, we had a couple of more. Okay. So, and then next slide, Mary Jane, if you want to just go to the next slide. So again, the Regional Chronic Disease Collaborative really appreciates all the work everyone's doing, and anything we can do to help, it would be great. And thank you so much, Mary Jane, for everything that you shared with us today. It was a powerful presentation and very valuable. So thank you so much for your time.
Thank you,
And I
Patty.
think-
I'm going to email you my personal email to give to your mother.
That is so sweet.
Thank you.
Okay, great. And then everyone else, I think we're good. If you would take a minute to do an evaluation for Mary Jane, feedback for Mary Jane, that would be great. There's a link in the chat for that. And we appreciate your attention. So thanks, everyone. Take care and enjoy the rest of your week.
Bye. Thank you.
All right, bye-bye.